Namaste. My name is Babu Matthew. I had been the professor of community oncology in the Regional Cancer Center Trivandrum from 1985 to 2004. The major objective of the community oncology division is to prevent cancer and to detect it early and treat it at an early stage so that the treatment cost will be minimum and you can save a life from dying of cancer. The mouth cancer was the commonest type of cancer at that time when I joined service in 1985. Today it is relegated to the second place. However, it is still a very common cancer among men in and around Trivandrum. The mouth cancer starts from pre-existing precancerous lesions. It very seldom occur de novo. The commonest precancerous lesion is called as leukoplakia. There is a Latin term, leuko means white, plakia means patch. So it is a white patch that is seen in the mouth. This is to be carefully noticed when a dental surgeon examines the mouth of the patient, especially if the patient is above the age of 35 and if he is a tobacco, arecanut, alcohol habituee, because these habits are the commonest cause for mouth cancer. All leukoplakias do not have a normal natural history, same natural history. Some of the leukoplakias are very benign and they very seldom undergo malignant transformation. Such leukoplakias are known as homogeneous leukoplakias. You can see the homogeneous leukoplakia in the picture. And such leukoplakias do not require a medical treatment, a prescription type of treatment. What is important is that the patient should take plenty of green and yellow vegetables, because these vegetables and fruits has carotenoids and lycopene in plenty, and that is enough to prevent the malignant transformation of homogeneous leukoplakias. The high-risk leukoplakias are the erosive leukoplakia and speckled leukoplakia. The speckled leukoplakia has got an element of fungal infection on the surface, and that's why you see the surface is granulated. It spotty surface, that's why it's called a spot or speckled leukoplakia. An initial treatment for a week to 2 weeks with antifungal drugs are necessary to treat speckled leukoplakia. The details of the treatment are shown in the picture. You can read and understand. The most dangerous potentially malignant oral lesion in the mouth is called erythroplakia or erythroleukoplakia. Here again, it is a red and white lesion. You have areas of white color and areas of red color in the lesion. That's why it is called erythroleukoplakia. About 20% or more of such lesions turn malignant within a reasonable period of 5 to 10 years. So such patients require aggressive treatment for a longer time, and it's better to refer to an oral medicine specialist to manage such condition if the general practitioner does not find time and is not confident in managing. The second precancerous condition is called as oral submucous fibrosis. This is characterized by a blanching of the entire oral mucosa and inability to take spicy food. The cause for oral submucous fibrosis is the use of arecanut, because the arecholine in arecanut produces changes in the collagen metabolism, which results in the atrophy of the oral mucosa. And any atrophic oral mucosa, when irritated by tobacco or alcohol, has got a higher chance of turning malignant. This is the rationale in treating oral submucous fibrosis. There is no specific treatment, but you can give symptomatic treatment for submucous fibrosis. And the important point one has to understand is that a constant follow-up is necessary, because a patient with oral submucous fibrosis has something we call as a field cancerization effect, meaning that many areas in the mouth will show malignant transformation. And when that happens, it has to be treated in par with cancer, and it is to be managed. I had a patient who died at the age of 85, who was under my follow-up for about 20 years. He had 4 independent lesions in the mouth, and all those were treated in the regional cancer center with wide surgical excision. And finally, the patient died at the age of 85, not because of oral cancer, but due to renal failure. Another common situation where a dentist meets is a traumatic ulcer. An ulcer in the lateral margin of the tongue or in the buccal mucosa due to sharp teeth, remaining roots, ill-fitting dental appliances, or unscientifically fabricated dental appliances. Initially, such ulcers are painful, and the patient may take some mouthwash or antibiotic and the pain may reduce. But a long-standing traumatic ulcer has to be viewed with caution, because at least a very small portion of cancers arise from long-standing traumatic ulcers. You can see in the picture an ulcer in the right lateral margin of the tongue due to a broken first molar, and the treatment for such situation is given in the picture. Now, the message I have to give you is that when you have a cancer in the early stage, either when you detect a potentially malignant oral lesion or a cancer as such, you have to discriminate between both. A precancer has to be treated by the dentist, whereas an invasive cancer has to be referred to a cancer treatment hospital. Because cancer treatment is not what nowadays is not what we used to give 50 years back. In those days, 50 years back, when I joined service, we were bothered only about the histopathology. Now the histochemistry, immunohistochemistry, and the molecular profile of cancer is to be studied before the state of the art is given to the patient. Because in addition to radiation, for management of oral cancer, we have several chemotherapeutic agents and also molecules which will specifically act depending upon the molecular profile. So don't play around when you have a cancer, even if it is a small lesion less than 1 centimeter, which can be excised in an easier way than extracting a molar tooth. Don't attempt it. As there is no consensus among dentists or among the doctors, I am giving this talk to make you aware that when a potentially malignant oral lesion is detected, you educate the patient and tell him that it is to be watched. And if it is a high-risk lesion, call him for follow-up depending upon the severity of the lesion. And if it is a less dangerous lesion, ask the patient to watch for signs of malignant transformation. When a lesion shows an exophytic growth from a portion of the lesion, or an ulcer which is painless with a indurated painless ulcer with everted margins, as you see in this picture, the patient has to be subjected for biopsy and subsequent diagnostic workup, which will help to save his life. This is a message I have to give you. Hope the new dentists, though they know the theoretical part of it, they may not have much experience. And many people have a taboo in treating cancer and potentially malignant lesions in their 5-star clinics. That's to be avoided. I agree that oral cancer is a poor man's disease. And some of the advanced cases will have a gram-negative infection, which is very characteristic of oral cancer, and such patients cannot be seen and invited to a dental clinic where patients from higher society is waiting. That's why many dentists do not treat the potentially malignant lesions or oral cancer patients. Well, this is a topic which I have been taught in oral medicine, oral pathology, oral surgery in detail, but I hope I have retired from active teaching, but still this is the dictum that we follow. Thank you.